If you're swallowing a small tablet every morning to manage your blood pressure and you're still dragging yourself through the day exhausted, watching your waistline expand, or finding yourself gasping after walking up a single flight of stairs, there's a very real possibility your doctor has you on a beta blocker. And what the medical literature is now telling us is something the majority of practicing physicians have yet to fully reckon with. That medication you've been trusting for years may quietly be working against your health. I'm Dr. Richard Holloway, and this channel is dedicated to translating the most current, evidence-based research on senior health into language that actually makes sense for adults over 60. If you haven't subscribed yet, do it right now, because what I'm about to walk you through could fundamentally shift the conversation the next time you sit across from your doctor. Let's dive straight in. Beta blockers. You likely recognize them by their brand names, Toprol, Lopressor, Tenormin, or their generic equivalents, metoprolol and atenolol. These drugs have been a fixture in hypertension treatment for more than 5 decades. Physicians write tens of millions of prescriptions for them annually. They're cheap, they're familiar, and for a long stretch of medical history, they were considered the unquestioned first-line standard for treating high blood pressure. Here's where things get complicated. The science has moved forward considerably, and for a large segment of seniors dealing with straightforward, uncomplicated hypertension, beta blockers are no longer the most appropriate option and may, in fact, be quietly making several things worse at the same time. Let me give you a clear picture of what these drugs are actually doing inside your body. Your heart is lined with receptors. Think of them as keyholes built into a door. Adrenaline is the key designed to fit those holes. When it connects, your heart rate climbs and the force of each contraction increases. Beta blockers work by physically occupying those keyholes so the adrenaline key can never fully engage. The result is a slower heart rate, reduced pumping force, and lower blood pressure. On the surface, that logic seems sound. And to be absolutely fair, for specific cardiac conditions, recovery following a heart attack, management of heart failure, stabilization of dangerous arrhythmias, beta blockers are genuinely critical medications. Nothing I'm saying today challenges their value in those contexts. But for seniors whose only issue is elevated blood pressure and who have no accompanying cardiac diagnosis, the evidence has shifted in a way that demands attention. The pivotal moment in this conversation came with the ASCOT Trial, the Anglo-Scandinavian Cardiac Outcomes Trial, published in the Lancet. This was a large-scale study tracking more than 19,000 patients with hypertension, comparing outcomes between those on a beta blocker paired with a diuretic versus those on a calcium channel blocker combined with an ACE inhibitor. The trial's independent monitoring committee stopped it ahead of schedule because the findings were too decisive to ignore. Patients in the beta blocker group experienced significantly higher rates of stroke, more heart attacks, and a substantially greater number of new type 2 diabetes diagnoses. The calcium channel blocker group, by contrast, saw 23% fewer major cardiovascular events. 23%. That is not a rounding error. That is a clinically significant difference with real consequences for real people. In the wake of that study, and others that followed confirming the same direction, the United Kingdom's National Institute for Health and Care Excellence formally struck beta blockers from its recommended first-line treatments for hypertension. They are no longer the preferred option in British clinical guidelines. And yet here in the United States, millions of seniors remain on these medications as their primary blood pressure treatment frequently because a physician prescribed them years, sometimes decades ago, and that decision has simply never been revisited. I want to pause here and ask you something directly. Drop a comment right now. Are you currently taking metoprolol, atenolol, or another beta blocker for your blood pressure? Just tell me yes or no. I genuinely want to know how many of you are navigating this. Now let me take you through the specific ways these medications may be undermining your health, especially once you're past 60. The first issue is fatigue and what's called exercise intolerance, and I want to be direct about why this matters so much more than most doctors ever explain. When beta receptors in your heart are continuously blocked, your maximum attainable heart rate is artificially capped. For a younger, sedentary patient, that ceiling might be completely invisible in daily life. But for a 6-7-year-old who wants to walk the neighborhood every evening, swim a few laps, work in the garden, or simply keep pace with grandchildren, that ceiling becomes a wall you collide with far sooner than you should. You feel breathless faster, your muscles fatigue more quickly. Physical activity feels disproportionately hard. And here is the cruel irony of that dynamic. Consistent physical activity is one of the most powerful and well-documented tools we have for naturally reducing blood pressure over time. When a medication makes exercise harder to tolerate, it undermines the very lifestyle behavior that could reduce your dependence on medication in the first place. It's a cycle that traps people without them ever knowing the trap was set. I had a patient, I'll call him Harold, 71 years old, who came in describing fatigue so debilitating he had completely abandoned his evening walks, something he'd done faithfully for years. He had been on atenolol for just over 3 years. In that window, he had gained nearly 14 pounds. His fasting blood sugar had crept into pre-diabetic territory, and his energy levels were, in his own words, like running permanently on half a tank. His previous physician had told him this was simply what aging felt like. When I sat down with him and examined his medication history alongside the current evidence, the picture came into focus very quickly. The second concern is metabolic disruption, and this one is extensively documented in the literature. Beta blockers increase insulin resistance, meaning your body becomes less efficient at processing glucose while simultaneously raising triglyceride levels and suppressing HDL, which is your protective, beneficial cholesterol. A comprehensive meta-analysis published in the Journal of the American College of Cardiology found that patients maintained on beta blockers carried a 22% higher risk of developing type 2 diabetes compared to patients on alternative antihypertensive drug classes. For seniors who are already managing blood sugar instability or who are sitting in that pre-diabetic gray zone, layering that kind of metabolic risk onto a medication that doesn't even outperform its alternatives in cardiovascular outcomes is a trade-off worth examining very carefully. What genuinely stopped me when I worked through this data myself is the following. Beta blockers do, technically, bring your blood pressure numbers down. The reading on the cuff looks reasonable. But what those numbers can't show you is the metabolic disruption accumulating underneath the shifting cholesterol ratios, the rising insulin resistance, the gradual erosion of your energy and your quality of life. You can produce a reading of 126/76 and still be quietly accumulating harm if the mechanism producing that number is simultaneously working against your metabolic health in multiple directions. The third issue is fall risk, and this is critically underestimated in older adult populations. Beta blockers are a known contributor to orthostatic hypotension, a sudden, sharp drop in blood pressure that occurs when you stand up from a seated or reclined position. That brief moment of dizziness or unsteadiness as you rise from a chair. For a 7-4-year-old, that is not merely uncomfortable, that is a fracture waiting to happen. Hip fractures in adults over 70 are associated with a 1-year mortality rate approaching 30%. A medication-induced fall is not a minor side effect. It is a potentially life-altering event, and it is one that should be weighed explicitly against the benefits of the drug causing it. Now, before I tell you what the evidence actually supports as stronger alternatives, I need to make something unambiguously clear, because this is the part that could protect your life. Never, under any circumstances, stop taking a beta blocker on your own without direct medical supervision. Abruptly discontinuing these medications can trigger a dangerous rebound effect in which heart rate and blood pressure spike rapidly, and in certain patients, that rebound has precipitated heart attacks and serious cardiac arrhythmias. Any transition away from this class of drug must be managed by a physician and executed gradually, typically across several weeks with consistent monitoring. What I'm offering you today is information and specific questions to bring into your next medical appointment. It is not authorization to open your medicine cabinet and make independent decisions. So what does the current evidence support as better options for seniors managing uncomplicated hypertension? Two drug classes emerge consistently and clearly. The first is calcium channel blockers, with amlodipine being the most widely prescribed in this category. The ASCOT data favored this class decisively over beta blockers. Amlodipine does not carry the same metabolic liabilities. It does not impose the same artificial ceiling on your exercise capacity. And a substantial analysis published in the British Medical Journal confirmed that amlodipine was associated with meaningfully lower stroke risk compared to atenolol in elderly hypertensive patients. The second strong alternative is ACE inhibitors and their closely related class, ARBs, angiotensin receptor blockers. Medications like lisinopril, ramipril, losartan, and olmesartan have demonstrated consistent benefit in older populations, including protective effects on kidney function, better outcomes in patients simultaneously managing diabetes, and a significantly lower fall risk profile. One caveat worth knowing: ACE inhibitors produce a persistent dry cough in roughly 10 to 15% of patients. If that's you, an ARB typically delivers the same therapeutic mechanism without the cough. I had another patient, I'll call her Dorothy, 74 years old, whose cardiologist made the decision to revisit her long-standing beta blocker prescription and transition her carefully over 8 weeks to amlodipine combined with losartan. Within 3 months, her fasting blood glucose had returned to a normal range. She had shed 7 pounds without any deliberate dietary modification. She told me she felt like herself again genuinely for the first time in several years, and her blood pressure readings were actually more stable and consistent, not less. Here is exactly what I want you to do with everything I've just shared. First, review your current medication list and determine whether you are on a beta blocker specifically and exclusively for blood pressure management, not for a diagnosed arrhythmia, not as post-heart attack therapy, not for heart failure, but purely for hypertension. The names to look for are metoprolol, atenolol, bisoprolol, propranolol, and carvedilol. Second, bring 3 specific, prepared questions to your next appointment. Ask your doctor, was my beta blocker prescribed specifically for hypertension, and does that indication still align with current evidence-based guidelines? Ask, have we assessed my fasting insulin and triglyceride levels recently and reviewed the trend? And ask, based on my complete health profile, would I be a reasonable candidate for transitioning to a calcium channel blocker or an ARB? Third, formally request a medication review. If you have been on the same blood pressure drug for more than 2 to 3 years without any reassessment, you have every right to ask for one. An enormous number of seniors are still taking medications that represented the standard of care in 2004 and have since been significantly reconsidered by the evidence base. Fourth, if a transition is recommended, get the specific tapering schedule confirmed in writing. A responsible clinician will reduce beta blockers incrementally, typically over 4 to 8 weeks, with regular check-ins throughout. Fifth, start tracking your own data right now. Keep a simple daily log, your morning blood pressure reading, your energy level on a scale of 1 to 10, and your fasting blood sugar if you monitor it. 3 to 4 weeks of self-collected data gives your physician something concrete and specific to work with, and it makes that conversation considerably more productive and harder to dismiss. One clarification I want to make before we close, because nuance matters here. There are absolutely patients for whom beta blockers remain the correct and well-supported treatment. If you have established coronary artery disease, a documented history of heart attack, diagnosed heart failure, or certain rhythm disorders, including atrial fibrillation, the risk-benefit equation is fundamentally different, and the evidence supporting beta blockers in those conditions is strong and well-established. Everything I've discussed today applies specifically to seniors whose sole diagnosis is primary hypertension, elevated blood pressure, without any accompanying structural or electrical cardiac condition. If that describes you, this is a conversation genuinely worth having. If your blood pressure medication is leaving you chronically exhausted, your weight is drifting upward without explanation, your blood sugar is trending in the wrong direction, And nobody has formally reviewed your prescription in years. You now have the research, the vocabulary, and the precise questions to walk into that appointment differently and advocate for yourself effectively. You are entitled to a treatment plan built on where the science stands today, not where it stood a generation ago. Leave a comment below with your current blood pressure medication. I read every single one, and your question may very well become the subject of a future video. And if someone you care about is struggling with their blood pressure management, please share this with them today. The right information, delivered at the right moment, genuinely changes outcomes. I'm Dr. Richard Holloway. Subscribe if you haven't yet, because next week I'm covering the silent mineral deficiency that makes blood pressure medications significantly less effective and that the vast majority of physicians never think to test for. I'll see you then. Take good care of yourselves.